Good evening, everyone, and welcome to Kawakib. Today we have with us Dr. Robert Klitzman, who is a professor of psychiatry at the College of Physicians and Surgeons and the Joseph Mayman School of Public Health, as well as the director of the online and in-person bioethics masters and certificate programs at Columbia University. Dr. Klitzman has written over 150 journal articles, 9 books, and numerous chapters on critical issues in bioethics regarding genetics, neuroscience, psychiatry, doctor-patient relationships, and other areas. Dr. Klitzman has received numerous awards for his work, including fellowships from the Joan Simon Guggenheim Foundation, the Russell Sage Foundation, the Commonwealth Fund, the Aaron Diamond Foundation, the Hastings Center, and the Rockefeller Foundation. He's a member of the Empire State Stem Cell Commission and the Ethics Working Group of the HIV Prevention Trials Network. Dr. Klitzman is a distinguished fellow of the American Psychiatric Association, a member of the Council on Foreign Relations, and a regular contributor to the New York Times and the CNN. Today, Dr. Robert will be talking about his book, When Doctors Become Patients, about what it feels like for doctors who get sick and what it can tell us about our current healthcare system and about the experience of becoming ill. With this talk, we at SHPPP have the pleasure of announcing a new webinar series where healthcare workers talk about their experiences with illness. And I might say it is now officially open with Dr. Klitzman, and the series is L.E.A.P. from the lens of the patient. Robert, you are welcome, and thank you very much for joining us. The floor is yours.
Great. Well, thank you so much for inviting me. It's really a pleasure to have a chance to speak with you. I'm sorry I'm not able to be there in person. I actually, 2 weeks before the pandemic, was in Jordan giving a series of talks at the King Hussein Cancer Center there. So I have a sense of some of the issues that are happening in the Middle East and that you may be facing, and I hope that perhaps we can meet in person at some point in the future. So as mentioned, I'm going to be talking about when doctors become patients, and I should say that I applaud the work that you're all doing and the efforts in this area that you're working on, because of course this is a large area that hasn't gotten the kind of attention that I think it should. And his background, as you all know, challenges arise in treating patients, especially these days with COVID, but in general, physicians, and I should say nurses, physicians assistants, and other clinicians face varying kinds of pressures due to changes in technology. There's new technology. There are healthcare systems that in the United States and elsewhere are not what we would like them to be. Unfortunately, there's often too little time and too much to do. There are tensions about how to balance technological and human sides of doctoring, these sort of apparently two different sides, some people say. There are questions of how to improve healthcare and education. So I looked in the literature and found that there had not been very much at all that was systematic in terms of looking at the experiences of doctors who become patients themselves and might therefore have insights into what it's like to be a patient and ways we can improve what we as physicians and clinicians do. So the goal of the study I conducted was to understand the experiences of physicians when they become patients due to serious illness, to understand what kind of challenges they face, how they address these, what lessons they learn that might be helpful to other physicians and nurses confronting illness and in themselves and others, and also to help patients. So I interviewed 75 physicians with serious illness. I conducted semi-structured qualitative interviews. I used grounded theory. And I found that there were a series of challenges that these physicians faced in becoming a patient, then in being a patient, and then in treating other patients. So in terms of becoming a patient, a lot of physicians resisted the role. Some said, I wear a magic white coat. One doctor said I was driving home on the highway and felt some pain, and it was in my chest and went to my left shoulder, and I wondered what it could be. Could it be a heart attack? And I went through the differential diagnosis, and then I went home and pulled out my medical school textbook a few years ago and looked up and saw, yes, an MI could present that way. So I got back in the car and drove to the emergency room So they are sort of seeing their own symptoms from the point of view both as a patient and as a physician, and that could lead to difficulties or challenges. They often delay seeking treatment. There's what I call post-residency disease, which is there has been a phenomenon described of medical student disease or illness, which is when medical students, as you may know or remember, when they read about various medical problems and lumps here and slight pains there, they start often to fear that they have these symptoms. Oh my God, I must have leukemia. I had trouble sleeping and I have a lump over here, etc. And it turns out it's nothing. Whereas what I found is that after residency, doctors actually have real symptoms and often ignore them. They're not good at taking care of themselves or seeking help from others. Many don't go for regular checkups. So I said, for instance, to one doctor, well, who's your doctor? He said, well, I don't really have a doctor. I have the guy who writes my prescriptions for me, and I write his prescriptions for him. So again, we don't always, unfortunately, practice what we preach. And I'll talk more about that. There's perceived stigma in becoming a patient. We implicitly often think, where clinicians and patients are somehow in the hierarchy below us, perhaps, or it's not good to be sick, or my colleagues may not like. If they find out that I have cancer, they may not send patients to me, etc. And they see help seeking as an inability to cope or perform their job. In other words, I'm used to treating illness. I know what to do. I'll take an antibiotic. I'll take this. I'll do that, and I'll be better. So they self-treat. They self-diagnose. They self-prescribe, and they self-prognosticate also. So there's self-doctoring. A few said I didn't look at myself as I would if I were a patient. And as I mentioned, they treat themselves and also think about, well, I should be okay tomorrow, or this should go away, etc. And they are engaging what I call denial systems or collusion, which is people around them often let them not take good care of themselves. So other doctors will say, oh, well, you must know what you're doing. I don't want to say, shouldn't you get that taken care of? Who am I to say something to my colleague? They must know what they're doing. And within families, as I mentioned this last bullet, if a family member, if a spouse says, gee, you haven't been feeling well, shouldn't you get that exam taken care of? Shouldn't you see a doctor? The doctor will say, hey, I'm a doctor. I know what I'm doing. Leave me alone. You don't know what you're saying. You're not a doctor. Other times they'll wear scrubs in the hospital when they're a patient, sort of as if they're still the doctor. Some prep their own chemo or meds. Some brought their laptop to the ICU and were going to write journal articles, but they wanted to. It didn't happen, etc. So other people around them sort of support them in not taking good care of themselves. In choosing doctors, they faced a number of issues and had a number of insights. A number said, empathy is important, and except in certain surgeries, most doctors are about the same, they felt, but they're, that little, occasionally there's one that's maybe that I know is better, but really I'm looking for someone who's going to be empathic. A number felt that clinical reputations were not borne out. So they'd say, I developed such and such a disease, and everyone said, oh, you should go and see Dr. So-and-so, he's the best. And they'd go see this person now as a patient, and they realized the guy was abrupt, didn't really listen, missed certain things, etc. So that the degree to which reputations may in fact be based on publications or prestige rather than how the doctor actually is with patients. There are also issues that came up with VIP treatment, very important person treatment. So a number of doctors said, gee, I could be treated in the hospital where I work, and I'll be treated as a VIP. And I'm sure I'll get great care, but then everyone's going to know what I have, even though, yes, you're not supposed to look up other people's electronic medical records. Word's going to get around that Dr. So-and-so is in the ICU or Dr. So-and-so's in the hospital, and I'll lose privacy. So some doctors said I went not to the hospital I worked, but to my local hospital, which isn't as good, and I had more privacy, but I can tell they were doing things wrong, or they just treated me like anyone else, and it was terrible. So again, there are trade-offs involved. And I think either way, there needs to be improvement in the system. there were issues that came about how to pick a doctor. What is a good doctor? So a number of these doctors I interviewed reflected on that. A few said things like the following. One said, well, I realized that when I was looking for a specialist, I asked particular people who had good taste in doctors. And interesting what that is, what that means. But there are also different styles of doctoring. So people also commented on the fact that they know that if they go to Dr. So-and-so, he is very aggressive and is going to intervene. If they go to another doctor, that doctor is more likely to say, well, let's see how things go and be less interventionist, et cetera. And I think that's an aspect of clinical care that we don't pay enough attention to, which is how there are often different styles or leanings one way or the other. There were issues of whether to tell others, to tell colleagues and others about that one is sick. So people found it difficult to tell colleagues, gee, I was just diagnosed with cancer. I don't want to go there. And yet there are work friends that we all have, people at work that we're friendly with. There are some people told their boss who said, I don't want to know too much because I don't want it to affect my decisions about you on a work basis. And so when a physician or nurse has a illness, an ongoing illness, there are questions about how this information should be handled. And at times people felt peripheralized. People said, well, I was diagnosed with cancer and suddenly people didn't refer patients to me anymore, et cetera. Or I was passed over to be the chief of the unit. I wasn't fired, but I wasn't promoted. So again, there's subtle kinds of discrimination that can occur as a result. Then in terms of being patients, there are a number of issues that came up and people face challenges. A number became more aware of screw-ups in care. People said, I noticed that my temperature was written down as 105 instead of 100.5. Luckily I picked them. They suddenly ordered a fever workup and I felt fine and I was able to pick this up. But of course, a lot of patients wouldn't. There are also an increased realization about non-specific symptoms and routine tests, so on, quote unquote. So a number of doctors felt, for instance, ongoing fatigue or ongoing nausea that was just kept going on. And these doctors said, when I treat patients, if they complain of nausea or fatigue, we say, yeah, but we don't give it that much attention because it's non-specific. We're not really looking at it per se. We're looking at focused on other symptoms or signs. And yet I realized how horrible it is to have an ongoing fatigue or ongoing nausea where it really impedes my life more than I ever realized when I was a physician treating other patients who complained of these problems. Similarly, routine tests. So doctors would, for instance, be waiting for a blood count to come back, and they were very anxious because it was going to show whether their cancer had come back, let's say. And so they were aware how these tests that we consider routine are routine for us as the doctor, but hardly routine for the patient. And they became much more aware of how we use these terms, such as routine, and therefore treat it lightly, whereas for patients, it's still, of course, extremely important. Doctors became much more aware of problems in the physical plant. In the hospital, the windows were cracked, the hospital food was bad, a loss of dignity. So they described suddenly just wearing a little gown with nothing underneath, no underwear, sitting in the hall and it's cold. And these are things, of course, which we think nothing of, or many of us think nothing of when we treat patients. The patient needs an x-ray, so they'll be sitting in the hall for maybe 45 minutes, just it may be cold, the hospital food's no good, and we ignore these complaints. But when you're a patient, these doctors realize how important they were. These doctors also became aware of how poor communication was at some time. So one surgeon said to me, for instance, that the night before he underwent surgery as a patient, his surgeon said to him, there's a 5% chance you may die tomorrow in the operating room. And this surgeon said to me, that night I couldn't sleep. I was so anxious. And only later did I realize that my surgeon could have said to me instead, there's a 95% chance that things should go okay tomorrow. And the surgeon turned to me and said, I've been a surgeon for 40 years. And I never realized that those two bits of information that are statistically the same, 5% chance you may die, 95% chance things go okay, they're statistically the same, but I never realized how different they were emotionally for a patient to hear. So again, these are things that I think are important lessons for us who are still treating patients. There was a desire to please doctors that came out. So a number of these doctors said that their doctor would say, everything okay? And they'd go, yeah. Or the doctor would walk by on rounds, everything okay? And they'd go, yeah. And they'd realize suddenly, well, why am I saying everything's okay? Everything's not okay. I still feel pain. I still feel tired. I don't feel well. But I realize I'm trying to please my doctor. Because if I say, yeah, I'm a good patient, everything's good, the patient will like me, the doctor will like me more. And these doctors said, I realized that if I feel that way about my doctor, that my patients must feel that way about me. And I never realized it. So again, these doctors, again, became more aware of these kinds of issues. The importance of touch, these doctors became more aware of. So a number of doctors said, my doctor said, I had a bad prognosis, and my doctor put her hand on my hand and said, we're doing everything we can. Or she put her hand on my shoulder, and I felt so much better, calmer. And I never realized that that kind of touch can actually make patients feel better. And I'm more aware of that now. There were questions about what is a good patient. So a few doctors said things like, gee, the nurses said to me on the ward when I left, gee, you're a good patient, you never complained. And I suddenly thought, well, should that be the definition of what a good patient is? Someone who never complains. That's not necessarily what a good patient or how we should define good patient. So again, these questions, what is a good doctor? What is a good patient? Are things that you're suddenly forced to reanalyze, or they were. So change experiences of time and an awareness of experiences of time. So I became aware that there was a difference between patient time and doctor time. So and of course, time is relative, Einstein and others tell us, but a few doctors said things like, I was waiting to see my doctor and he kept me in the waiting room for 45 minutes. I was driven up the wall. And I said, well, have you ever kept patients waiting? And they'd say, well, I guess I never thought about it. And they now say, some of them, when they ever say, see a patient, gee, I'm sorry to have kept you waiting. And a few of these doctors did. And they said, I have no idea if the patient was kept waiting, but I find that it sort of reduces the tension in the room that I never realized was there before. Also, with the way we talk about time is often vague, sometimes purposely vague for the doctor's point of view, but then ways that may not be most helpful to the patient. So these doctors said sometimes that their doctors would say to them, gee, well, your cancer shouldn't come back too soon. What's soon? How soon? You should be well for a while. Well, how a while? So again, we talk in vague terms often to cover ourselves, but for patients, this can be very upsetting or feel vague and uncertain and unsettling. There were also issues about getting results of patients sooner. So a number of doctors said, well, I was waiting for my lab results and it was a Friday afternoon and I wasn't going to get them till Monday. And I now make a point to try to get results to patients sooner. Of course, now with electronic medical records, this is often easier. But there's a way in which, of course, the word for being patient, which to wait, and patience is suffering. So waiting is suffering linguistically in at least English language from Latin. And it's important to be aware how much waiting often is suffering. There were mental health and psychiatric problems that these physicians faced, a number of them, that were hard for them to deal with. So a few said that they now, for the first time in their life, had significant depression or anxiety. And yet they found it hard to talk about these problems with their providers. So also sexual side effects. So one doctor, for instance, said, my doctor said, well, how you doing? I'd say, oh, okay, everything's okay. And but I didn't say, actually, I'm impotent on the new meds. Could we do something about it? And it took 3 months and 3 visits for me to feel comfortable raising that. So, of course, if doctors feel uncomfortable raising that, patients will undoubtedly too. Similarly, doctors would say, my doctor would say to me, how you doing? I'd say, well, okay, fine. Finally, it took 3 months for me to say, actually, I'm depressed. Could we get treatment for that? Can I get treatment? So some have said I've become much more aware of these issues. I've become like a social worker, quote unquote, much more aware of the mental health problems that my patients may be facing and try to get treatment and be proactive about that. Doctors also looked at risks and benefits differently. So one doctor, for instance, had been diagnosed with a rare lymphoma and said that he got this diagnosis, and then a week later flew out to the West Coast in the United States to be the second patient in a new protocol. And I said, well, would you ever recommend that for your patients? He said, no, but for me, it's okay. I mean, I can practice research level medicine. I understand the risks and benefits, et cetera. So again, some patients may want to do that, but there's sort of a question about, is there a double standard? Not ignoring side effects, as I mentioned, seeing errors, second opinions is taboo. So a number of doctors said, gee, I want to get a second opinion. I felt awkward asking, or my doctor, when I told him I was getting a second opinion, got annoyed at me. So again, I think these are issues too, the way psychological factors may affect our ability to just give as good treatment as we can. So as I mentioned, there are taboos about anxiety, depression. Some doctors said, well, I wonder, is it okay for me to cry? I got terrible results and I'm in my office as a doctor, and I wondered, is it okay for me to cry? Is that going to be weak, et cetera? So again, we put up these internal and external barriers in being a physician, and yet when we're patients, it's hard to shift modes, to put on a different hat. Even that as a metaphor is too weak, but to take on a different role. And a lot of these doctors had to confront workaholism. A number said, gee, I've always thought I'll be super doc. If I'm busy helping others, I won't get sick, I won't die. Helping other patients, being and succeeding in medicine, which is a very competitive field, requires long hours, lots of dedication. It gives meaning and structure to us. It gives us rewards. You're moving ahead, you're doing well. It could be self-perpetuating. For a number of people, it was an excuse not to have a social life or deal with one's family. These doctors would say, well, if I would say, well, I can't go to my son's athletic event, or can't watch my daughter in the play, or can't go to the picnic because I have work to do. And it was a way they realized of sort of putting up a wall. And they now realize that was not a good thing to do, many of them. They now reprioritize their lives. Some worked while they were sick. They felt that taking a sick day, they felt guilty. They viewed health as a reflection of competence. If they're healthy and working hard, that means they're good, et cetera. And to get sick is put a damper on all that, or really block that. They face questions also about retirement, about should they retire now they're sick, when to retire. It was difficult. Some worked harder when they became sick. The doctors had metastatic cancer and still kept working pretty hard. But they also wondered, if I'm not working, what do I do? And a few said things like, gee, when I retired, when I got sick, I retired, I made a reservation at the restaurant, and I don't know, should I say it's Dr. Smith or Dr. Husan, or do I just say Mr. Smith or Mr. Husan? Do I still call myself doctor when I introduce myself? Or if someone introduces me as doctor, do I say anything? And at first I thought this was sort of a joke, but it didn't really matter. But I realized it reflected whether we are what we do, or whether doctoring is what we are or what we do. In other words, are we still a doctor if we're no longer doctoring? And in some ways, of course, it is part of an identity, not just a job. So some reinvented themselves. Some said, gee, I can't work long hours, so I've moved into hospital administration. Some volunteer to teach, even though they can't have the stamina to work long hours treating others, but they can teach or do other things. They use skills another way. They spend more time with family, but they need to readjust. Now, what do they do with their time? And there were issues about spirituality. So a number of doctors said that in the past, patients would say to them, doctor, would you pray for me? And these doctors would quote, poo-poo it. They'd say, yeah, whatever. And they wouldn't do it, or wouldn't matter to them. And they now realize how important spiritual and religious issues are. Now, I should say, I did these interviews in the United States, so I'm not sure how these issues or what these issues are like, or how they play out in Lebanon today. And I'd actually be interested to hear. Some said, I wish I could believe in something, or I wish I could believe more in something, but I'm a scientist. I'm used to the facts, and so I'm a little bit wary about religion, etc. And there were different themes that came out. Some followed a religious tradition, and we in the United States have various religious traditions. Some people are Catholic or Protestant or Jewish or Muslim or Hindi. Some are wary of organized religion. Some practice rituals without acknowledging the belief. They would do. They didn't really believe, but they did. They would do whatever the religious ceremony was. Some mix and match beliefs. They would say, "Well, I used to be this, now I'm that." Some had very non-specific beliefs. They believed in just spirituality. One doctor said, I believe in the third law of thermodynamics, that energy is neither created nor destroyed, it just goes on. They wrestled with whether spirituality was involved in health events. Well, if I pray, will that get rid of my symptoms? Will it help me? And of course, these are questions that patients ask as well. And they wondered this. Some were spiritual to start and didn't change much. Some became more spiritual or religious. Some were spiritual despite themselves. Some were spiritual but didn't think of themselves. Some wanted to believe but couldn't. They said, I'm too much of a scientist. Some had doubts, etc. So it was a wide range of responses. And what was interesting is it suggested how hard it is even for patients to describe spiritual religious views, incorporate those into their work, teaching it, and to be patients, the doctors to be aware of it, etc. And again, I don't know what these issues look like in Lebanon, but I'd be interested in hearing about that. So there are also complementary alternative medicines, vitamins, Chinese herbal medicine that a lot of doctors were wary of before, but now they used. So they would say, patients would say to me, well, they're taking herbal medicine. I'd say, well, whatever, I don't really think it works, but if that helps you, that's fine. But many of them are doing this, even though they've been quite wary earlier. After I did this, I was in Greece a few years ago and went to Epidaurus, which not far from you all, which is the largest intact theater from the ancient world. And if you drop a pin on the stage, all 10,000 people can hear it. This was built in 300 BC, I believe. And it's famous, this theater, but I realized that the theater was part of a hospital complex, and there was a hospital, a temple, and a theater all together. And I thought that combining those things, having not just the hospital, but having a temple and a theater were important. And I think in a lot of Western medicine, at least in the United States, we focus too much often on the biological and the technological, and not as much on the spiritual issues. There were also issues of interacting with patients, of sort of us and them. And a number of doctors said that they saw it as us and them, us the doctors, those the patients, and they now tried to reduce the hierarchy, but that it was still important. And they wondered how close to be. Do they give out their cell phone number? Do they give out their private email? How do they decide? Sociologists have said that physicians have detached concern, where they're concerned but detached. And these doctors then question the kinds of boundaries we have with patients. Some made changes in how they interacted with patients, whereas if patients were, let's say, were overweight or obese or diabetes and were still eating a lot or eating lots of salt, if they had cardiovascular problems, they would say, look, you have to stop the salt, you have to stop the bad food. Now they'd say, well, they realize they themselves would often go to McDonald's or eat bad food, junk food, when they shouldn't. So they realize how hard it is, and would say to patients now, that's great that you were able to eat healthy food for 3 nights. Let's try to make it 4 nights this week or something like that. So they would try to frame things better to be more effective with patients. And so there were questions that came out in terms of helping patients. Can empathy be taught? And I think it was split whether you can, but I think that there are skills that we can teach, not to say, well, we're going to go for routine tests or use vague language, try to get results sooner. A number of doctors comment on how some doctors had an art of giving bad news, saying there's nothing we can do for you. And some of these doctors said that their doctors would say, gee, there's nothing else we can do for you. But others would say, well, there are things we can try. Your life would be different, but you can still have a satisfactory life. And a number of these doctors learn to ask now as a result, only as a result of being a patient, to always ask, do you have any questions? I'm sorry to have kept you waiting. Some would say they would now sit down with their laptop or chart rather than stand up when they're visiting a hospital and the patient in the hospital, the patient's lying down, but pull up a chair to be eye to eye. And a few said, well, I don't know if I could, sometimes I'm tired, but you can play act empathy. You can act like the caring doctor, even if you don't fully feel it, if need be, which I think is important insight. So I thought I'd wrap up to have time for questions and answers, and I'd be interested in your experience with these issues. So overall, the experiences of physicians who become patients raise complex issues, but can help us understand what we do as physicians, how best to help ourselves, our colleagues, our patients. I think there are implications for medical practice, both what we do as individual providers as well as what institutions do. I think that these insights can help with the education of providers, patients, and institution. I think there's a need for more research on some of these issues of how we can improve. And interestingly, also coping and self-care, at least here in the United States, is not really taught in medical school, and it's discouraged by much of the medical profession, but it's really important. I think physicians should select a personal doctor who can perform regular checkups, and that individual doctors should not self-treat or self-medicate. I think as a profession, we should promote health and wellness among physicians, particularly around mental health issues. And of course, there's a lot more awareness of mental health issues among physicians, especially in areas where there's been a lot of COVID and physicians really have been overwhelmed. So establish appropriate mechanisms to detect impairment, be supportive, refer, etc. There's a copy of the book, which is available on Amazon, etc., when doctors become patients. And I'd be happy to answer any questions. And again, thank you very much.
Robert, thank you very much. That's simply fascinating. And I can begin, before I ask any question, by telling you that if you were to do this study in Lebanon, I don't think you will get much differences in terms of results.
Mm.
So I will raise one question and then leave the floor to my colleagues. I noticed clearly that most, if not all, issues raised are relational, interpersonal, having to do with empathy and communication and what have you.
Yeah.
And I wonder if we are, as educators in medical schools, are one way or another guilty of transmitting the wrong message to our students, neophyte physicians, and to doctors. For example, if you look at stigma, and you mentioned they feel stigmatized when they're sick, is it because we indirectly make them feel that they are immortal, that they cannot be sick? Is it our problem? And would you agree that experiential learning, say, I remember we proposed this once at AUBMC, having students Med 1 or Med 3, depending, matriculating into medical school, but then spend 3 or 4 days as patients, wearing hospital gowns, eating hospital food, undergoing tests. It's economically a big problem, but where do you stand vis-a-vis this?
Yes, so great questions. Thank you. So yes, so the problem is how we as educators, and that's why I mentioned institutions, we promote these attitudes, these views. These doctors aren't getting it from, the thin air. They're looking around and they're seeing how often, even though we say, yes, we should treat patients respectfully, we don't. We barge in, we leave, we, only have a few minutes with patients. We don't have time to really listen to them. There are studies that show that that doctors interrupt patients all the time, every few seconds. Patients rarely finish a sentence before the doctor interrupts. And part of this is we don't have time, but yes, these are, really need to think about how we educate students. And of course, there's been research done on the so-called hidden curriculum in medical education, whereas we're taught, yes, listen to the patient, but doctors serve as role models, and students see how doctors are kind of brusque and kind of getting through patients on rounds pretty quickly, et cetera. So yeah, I think it'd be great for students to have to experience being a patient. I think even putting students in a wheelchair and for 2 days and saying for 2 days you cannot leave your wheelchair, and see what it's like to have to go to the bathroom or eat or get around, or how, there's stairs in lots of areas, or even if you need to get to work and you get on the bus or the tram and there's no stairs, or maybe there is, or I think even that would help with this, and is pretty inexpensive. And you can even say for a weekend, just you have to be in a wheelchair, and I think something like that could be very effective.
So thank you, Robert. I just want to say that I am on a wheelchair currently because I have a comminuted calcaneal fracture. And I did think it would be great to have a cast on the foot of my students for a while and let them see, make them see how horrible it makes your life.
Yeah,
So I will
absolutely.
stop at this moment and give the floor to my colleagues if they have any questions.
Don't be shy.
Yeah. Okay, so Dr. Hazar, Professor Hazar from Canada has raised her hand.
Yeah, thank you, Talia. Thank you, Dr. Kulsman, for this very interesting presentation. So my question is, did you notice or how, if any, your demographic sample has affected these results, these findings? For instance, let's say, did you notice that maybe becoming a patient as a doctor was more acceptable for some doctors from an ethnic or specific origin than others?
So very good question. Thank you. So I interviewed 75. It was hard to get doctors to participate. So I didn't have, it was about half male, half female. Most were Caucasian. I didn't have as many doctors from other races and ethnicities as I would have liked. It was just hard to get them to participate in this kind of qualitative research. It was a small number. So, but I think it'd be important to look at these issues with others as well. There were a few Latino physicians who I interviewed here in the United States who tended to be more religious. And of course, in general, in the United States, Latinos, people from Latin America, overall, statistically, are more religious. So, but that was the only thing I found. The other was in terms of age. I had some younger, some older. I think that younger physicians face, in some ways, a harder time, perhaps, in that if you're 75 and you develop a serious illness, it's more consistent with the fact that you're 75, as opposed to if you're 35 and have a serious, develop cancer. It's less typical statistically. So I think there were additional burdens that they faced in many ways, but that's not to minimize the kinds of burdens that older physicians face, especially because physicians, even if they're 75, lots were still working hard and engaged, sometimes in research or other things. So the degree that medicine was sort of really an integral part of one's life. It wasn't a job like, working in a shop where, you retire and that's it. I think it really was part of people's identity.
Thank you.
Thank you, Robert. We have Dr. Kamal Badr, who is Associate Dean and Professor of Nephrology, who has his hand raised. Faddal, Kamal.
Yes, thank you, Talia. And on behalf of the school, I just want to say thank you to Dr. Klitzman for this lecture and for taking the time to be with us. I also want to thank Talia for everything she's been doing over the years to inculcate these themes in the curriculum and to help us deliver the humane side of our curriculum, both openly as well as the hidden curriculum. And I didn't realize you were in a wheelchair, Talia, so I wish you all the best and hopefully for a quicker recovery. A few years ago, we had a big meeting here on the future of pre-medical and medical curricula in terms of including humanities, humanism, humanities-related themes, and technology, and how to marry those two in the future curricula. And one of our guests who co-organized the conference was Dr. Rita Sharon from Colombia, who, as you may know, of course, has championed the field of narrative medicine. And I'm interested to hear how you feel that narrative medicine can contribute to developing those traits or those characteristics in the physicians and budding physicians that we'd like to develop, and in ourselves too, and how much you think we can inculcate it in a more formal way throughout the medical curriculum.
Yes, so those are great questions. Thank you. So yes, so I think narrative medicine is a very important approach. I would say there are others. So I work in bioethics, and one approach in bioethics is to make students very aware of certain basic principles. So principles of autonomy and respect for persons, to respect patients' choices, issues of beneficence, of trying to increase the good that we do, issues of trying to avoid harm or non-maleficence, avoid lower risks, and issues of social justice, making sure that we're not disproportionately favoring or burdening any particular group. And those may sound simple, but in fact, they come up in many complex ways. So for instance, who should get the first vaccines? In the United States at the moment, there are debates, should we be giving booster shots in the United States when there are people in many countries who haven't gotten one shot of a COVID vaccine? So one is areas, if you have a limited resource, ICU beds or vaccines, et cetera, who should get those, which is not a narrative medicine issue so much as being able to think through what are the benefits of giving it to whomever, what are the risks of giving it not to people, making sure that it's a fair way. You don't want to say first come, first serve. You don't want to say we're just going to give it to the wealthy people. So I think being able to think through issues like that are important. Similarly, with various treatments. So some treatments are very expensive. When do you give a generic treatment versus a more expensive treatment? How do you weigh maybe the more expensive treatment is slightly better? Does that always justify the additional cost? So I think a bioethics framework can also help. And these issues come up at the bedside also. If a family member says, I want you to do everything you can to keep a patient alive, but the patient had said, no, if I'm going to be a vegetable or not of a quality of life, I don't want futile measures taken. So again, being able to weigh what are the rights of the patient, what are the rights of the family member, to say what happens to the patient, what are the benefits, what are the risks, to be able to weigh, to think about those skills, I think is also important.
Yeah, if I may follow up, Talia, I agree with you totally on the importance of these themes, but I found the power of narrative medicine is in the individualization of the delivery of these themes.
Yes.
And the need to really know much more than we do now know about the patient's life, their whole circumstance of their, which has nothing to do with their disease, but which is going to be extremely impactful on the way we treat them, with the way we can or cannot treat them, and so forth. And I'm wondering how much more we should stress that obtaining that kind of information in a of course respectful and correct manner, as much as we do the physical exam and the review of systems and all of those things that we keep stressing in our formal teaching.
Yes, good question. So I think it's important. So, I mean, narrative could be used in different ways. So one, as you say, extremely important that we understand where the patient's coming from, patient's background, issues that might be involved in the patient's illness, and of course in the patient's treatment, et cetera. The other is, I think, even in communication. I mean, some of a lot of the insights from the book, for instance, have been taught or incorporated in medical curriculum in various places. But even the anecdote, for instance, about the doctor saying 5% chance you may die versus 95% chance you may die tomorrow. Like I think to be self-reflective for doctors to think through even how we use terms and speak in ways that are may not be as sensitive as we think. We may want them to be sensitive, but under the pressures, I think, to be able to sort of think critically about what we're saying. So I think giving examples of, inadvertent perhaps things that doctors have said that are come across as insensitive or important, and they may be insensitive in ways that, or be heard as insensitive in ways that doctors aren't aware of. So again, I'm not sure how. I'd be happy to talk to you more about it to understand, what you're now incorporating and doing. But in terms of whether ways you might be able to do more, I certainly think it's worth thinking about. I think small discussions groups, which I'm sure you're doing as well, is another very helpful way of addressing these issues. Play
Thank you.
acting with patients, yeah. Role playing, yeah.
I see a question in the chat, Q&A. It's from one of our Sharpie students. Health professionals, when they are sick, they become very demanding and interfere with the medical management. So do you have any comment on this?
Yeah, I don't see the chat. But anyway, just
Q&A. If you go to the three dots at the down corner, it says panel options, and then you get the Q&As. Tala or Diana, can you help please here?
Sure. There's a question mark in the Q&A options.
all right. What
you
are
want, I can read it.
Just read it to me again. Sorry.
Yes, of course. Health professionals, when become sick, very demanding and interfere with medical management. Please
Yes.
comment.
Yes. Yeah, so I think it's important to realize that health professionals often feel very helpless. They're used to being in control around illness, so they feel helpless, and also they are used to having power. So they're used to being, I decide what to do if a patient has heart disease or something. So a lot may be a power struggle, particularly it may be an older patient who's a doctor with a younger doctor who's treating him and her or her. So I think being sensitive to these issues, I think one, being aware that this may happen, and I think in general, often with VIP patients, they can be very demanding because they're used to having power in their lives, and physicians have power. So I think addressing this, I think setting up ground rules, saying, look, I'm happy to treat you, but here are the parameters. If you want me to treat you, and I'm happy to do so, you need to follow what I say. I'm the doctor. You're the patient. If you feel that I need to know what you're doing. If you want, we can talk about it. But if these are not acceptable to you, maybe another doctor would be better for you, or something like that. I think to lay out the ground rules, because one of these doctors said, gee, when I was in the hospital undergoing surgery, I brought my own opioids with me, my own pain meds in a little plastic baggie, so I wouldn't have to bother the nurses when I wanted to take pain meds. Well, that's very nice, but of course, the problem is it can get in the way of treatment, where suddenly the patient's is comatose, or the patient is, lethargic, and the staff will say, well, they haven't gotten any pain meds. I don't know what's going on. So I think often it's doctors not communicating what they're doing as patients is part of what makes it difficult. So I think laying out the ground rules, and the doctor being empathetic and saying, I know this is hard and you're switching roles and it's a difficult thing, but we really need to work together as a team.
We have a question, I think, in the chat.
Let me read it for you.
The doctors who became patients also have different perspectives on other members of healthcare team, such as nurses?
Yes, thank you. A lot recognize how important, or comment how important nurses were. One doctor said, for instance, when he went to the hospital, he didn't have a personal doctor, and he needed to find a doctor. Actually, this was the doctor who went home to look in his textbook about his cardiac problem. So he pulled aside, said, I realized the person who knows best is the head nurse. So I pulled the head nurse aside and I said, who's the best doctor here for cardiac problems. So I think a lot realized how important nurses were. They became much more aware of, as I was talking with Dr. Kamal Badr about, the humanistic side. And so, yes, they became, I think, more aware of how doctors are just one part of the team.
Any
Uh,
other questions?
we have another question also. Did the fact that doctors treated the patient differently once he was introduced as a doctor?
I'm sorry, say it again.
So I'll rephrase that. I think the question was, let me see, was the patient treated differently by the doctors once they knew that he also was an MD? Did it change
Yes,
the
yes,
treatment?
yes. So always. So if doctors know they're treating another doctor, that doctor is a VIP and gets treated differently. And that could be good or bad because sometimes you get, you don't have to wait as long in the emergency room. The doctors return your calls more quickly. However, we know that VIPs often don't get good care because the usual protocols are avoided. So if through these doctors said, gee, I'm a doctor, no doctor's ever done a prostate exam on me because they feel, well, I'm a doctor. It's too uncomfortable to do that, for instance. Or they don't ask me about different things because I'm a doctor. They think I'll know how to do that. Or they didn't tell me the side effects. They assume that as a doctor, I knew. So it cuts both ways that being a doctor gives you VIP treatment, but that could be mixed. We know that in the United States, when Michael Jackson died or the musician Prince died, they got terrible medical care because no one wanted to say, gee, Michael Jackson wanted to take a drug that was normally given only in the hospital. We want to take it at home. And a doctor said, sure, we'll do that. We'll bend the rules. Or Prince was, people around him said, gee, you need drug treatment. And he said, no, I don't want it. And no one said, okay, you really need drug treatment. So in the same way, there are doctors who, if they don't do what they should be doing, with the earlier question, their doctors may not say, look, you really have to do this. I mean, it's uncomfortable talking to a colleague like that because the relationship is no longer doctor to patient, but now doctor to fellow doctor. And so it's harder to, press or to exercise authority in a way that might be good.
So if we don't have any other questions, I want to be respectful of your time, Robert, but I would like to end with one closing question, maybe. What are we doing that is wrong? In other words, should we accept to be ruled or governed by a system which is basically market-oriented, that affects how we treat our patients and how we eventually will be treated once and if we become sick?
Yes. So we need to, as we mentioned earlier, we need to realize that these human sides of healthcare are very important, is one. We need to teach doctors, and I would hope that the lessons from these doctors I interviewed in the book, et cetera, and as I've been talking about, could make us realize ways we could communicate better, ways we could treat each other as fellow healthcare providers better, the importance of the human side of being aware that we're keeping patients waiting, being aware of how we communicate and how it's not just statistics, but the way emotionally the statistics we present are framed that affect the way patients hear them and will respond to them and react to them and feel about them. So I think that these more human sides to me came out very strong in talking to these doctors. I think those are all things that we can all incorporate in what we do every day as providers in terms of both with the patients we treat, but also as educators, what we teach others, how we interact with colleagues, et cetera. So, and those of us who are helping to run institutions to be aware of these issues as well. So I think there's a need for more awareness of of these issues of needs for compassion, etc.
Thank you, Robert. Thanks a lot. You're starting your day. We're about to close ours or to end ours. Any other questions or remarks before we close the session? Thank you for being part of Kawakib and more officially LEAP. And we'll talk later. Thank you. Thank you
Great.
all.
Thank you very much. Nice to meet you all. Bye-bye.